And thank you so much for joining us this morning. And welcome to the Division of Public Health at the University of Free State in South Africa. And this is an implementation science project in partnership with Central University of Technology. And I will introduce my colleague here. He will just say a little bit on the project, and he will also introduce himself and his institution. Thank you.
Thank you so much. I'm Lebogang Mogongwa from the Central University of Technology in the Free State. It is only like 3 km or so down the road. So yeah, we are here working on a partnership with in this project where we applied for funding, and we are here to build capacity when it comes to implementation science. And so it involves a bit of workshops, and then from there we see how we can come up with projects that we can work on this particular discipline. And we are very excited to have our international expert here, Dr. Shalini Ahuja. And yeah, I think you are welcome here, and we wish to have a fruitful learning session. And in that way, it will be great for this particular week. So for the first 2 days, we'll be on this side, and then the last 2 days will be at the CUT side. Thank you so much.
Thank you, Doc. Let me start by thanking the funders of the project, that is our Research Directorate at the University of the Free State and Central University of Technology. And we're not working alone, we're a team. And we have our team members with us here this morning. I would like them to stand up so you can see them. And when we are networking and we have more time, we just introduce each other individually. Could our team members please stand up so that everyone can see them? You can stand up. And we have 3 at the back. And we also have community organization partners over there. Yes, and we have a representative from Department of Health as well, who came with her colleagues. And yeah, thank you very much. So these are our partners, and the other colleagues were in the committee that made everything possible. Thank you very much. Thank you. And having said that, I would like to thank the team that is working with us today. We have our IT department. They've been so kind to come on board. And then we have our camera crew as well from Center for Teaching and Learning. And they are here with us to assist with the proceedings. Thank you very much, colleagues. And again, we thank Dr. Ahuja, who flew all the way from King's College London to be with us. She is an expert in the field of implementation science, and she trains in low and middle income countries. She travels a lot, she teaches, she supervises students, but she made time for us. Thank you, Dr. Ahuja. I'll give it over to her to get started. Thank you.
Thank you so much for that introduction. Really appreciate it. Not used to speaking on the mic, to be honest. I don't know how that sounds, but good morning, everyone. I'm Shalini, and I'm really pleased to be sort of sharing some of my learning on implementation science. That's through some theoretical understanding, but also through some experience I've had over some of the years. So I sit in King's College London as an assistant professor. We call sort of lecturers or senior lecturers. There's a different terminology I gather in this country. And I'm clinically trained as a physiotherapist, but I've been working as a methodologist across different disciplines, starting from mental health and sort of antibiotic use to sort of surgical site infections as an implementation science expert. It's not rocket science that you'd learn, but I think some of the funders across the globe are really keen in sort of embedding implementation science principles in research programs. Okay, without further ado, I'd make a start. So essentially, the objectives for the session today are getting acquainted with each other, trying to sort of understand the concepts, key concepts of implementation science, and then we will move on to doing some workshop to see if we really understand these concepts, and then sort of workshopping some of the ideas with you later this afternoon. I think it's very important to know who are the people working in this field to get an understanding of what the field is. So I'll start by my journey, and then potentially that will instigate some thoughts in you and see if you are also an implementation scientist as we speak. So I trained as an orthopedic physiotherapist, and then I worked as a physiotherapist in the mental health wards in Maudsley Hospital. So this is in South London. And it was established actually as a military hospital in 1913, around that time. But then later turned as a sort of a psychiatric hospital, one of the first in the Europe, I hear, around 1922-23. And patient-centered care was always the focus in the hospital, and increasingly so interprofessional care. So they included different healthcare professionals, health and social care professionals like myself, physiotherapist, in sort of managing the complex needs of people with mild, moderate, or severe mental health issues. After working for a while, I understood I really need to sort of do an MSc, and I went up to Leeds. That's the Parkinson Steps on the Leeds city campus, and we sort of, I did my MSc in Health Services Management there. That was a public health degree, which was really helpful, and we got to work with Alan Fisher Institute of Mental Health in UCT, University of Cape Town, with Professor Crickland. And we tried to work and understand how policy implementation happens. So we were looking at early developments in mental health policy and its implementation. So that was a part of sort of research I did with the university. I think I enjoyed myself in Leeds a lot, and still managed to get my degree, which was great. Thereafter, I was working in a few countries, and I realized there's something called as research, and there's something called as implementation. And I realized the gap in the two. And I'm sure some of you who work in the field are frontline workers, or you do research with the health and social care professionals, you really know that difference. And that sort of really disturbed me, and I thought I really need to understand the science behind implementation, or if there's any that exists. So I got some funding from European Commission to do my PhD in health services research on a project called Emerald, which was emerging mental health systems in low and middle income countries. So this was in Uganda, Nigeria, South Africa, Ethiopia, and Nepal and India. So essentially we were trying to understand how do you strengthen mental health systems. So mental health system, if you look at the WHO sort of framework, encompasses various components such as governance, service delivery, information systems, health workforce, and financing and economics. So we're trying to strengthen every aspect of mental health system to ensure there's equitable access to services for depression, psychosis, and alcohol use disorders. So I managed to sort of visit what do they call it, do a helicopter view of sort of evaluation in these countries. But it was really sort of enriching still to understand how different systems work, sort of at a provincial level in this country, at a sort of a state level in countries like India and Nepal. So that was very sort of helpful. So we tried to do as much as we can in terms of scaling mental health services, sort of low-cost interventions. Then I started doing postdocs. So this was all at King's. So I started doing various postdocs. One of the common cross-cutting theme in these projects is, in some of them I was working as a clinical expert, but in the others I was more of a methodologist, so providing insights on research methods, which were primarily implementation science research methods. So we looked at surgical site infections and how to sort of optimize antibiotic usage in surgery in a few sort of hospitals across the globe. So sort of not comparing and contrasting because the contexts are so different. But we looked at Guy's Hospital in London, which has the least surgical site infection rate. This was before COVID, so things would have changed by now. And Grootskoor, I could never pronounce it well, Grootskoor in UCT in Cape Town, and also Amrita Hospital down in south of India. And yeah, and I think COVID struck during the project. So what was interesting was there was a lot of south to south collaboration. So it wasn't somebody from Guy's Hospital telling, well, you know, do double gloves wearing, you know, things like that. But it was more of, there were more knowledge exchange or knowledge mobilization, as they call it, between Amrita Hospital and Grootskoor, which I found really sort of interesting. And I've mentioned that we involved sort of more behavioral, structural, and technological interventions. So understand, essentially trying to change behaviors, which I was speaking to some of your colleagues yesterday, how hard that is to do at an individual level, but also sort of changing the context or sort of understanding the context. Some of the other projects that we work in is, one of them is called Mental Health Implementation Network. That's still active, actually. Essentially, we try to prioritize key mental health services that should be implemented and that have evidence of implementability, and really sort of rolling that out with our partner organization, community organization, and provider trusts. So a group of hospitals, essentially, to sort of make it in lay terms. And what we're trying to do is essentially address the care gap in mental health. So there's a lot of evidence sitting on the shelf that says, well, look, for example, parent-delivered cognitive behavior therapy with the help of school counselors is a very effective, clinically effective intervention, but nobody is rolling it out. So how best, or what sort of strategies can we use to roll out some of these interventions? So we're working in 3 areas. First of all, we're trying to improve, and this, sorry to say, this is a project across England, so from regions from north to south and east to west. And essentially sort of trying to improve mental health of minoritized population. And the second is improving children, young people's mental health, and trying to have integrated care protocols for alcohol and substance misuse problems. So that's the sort of 3 prioritized area. We know what works in these 3 areas, but hasn't been rolled out. So we're trying to understand the implementation. Some of the other projects that I'm involved in, which has just started, recently got funded, is improving maternity and neonatal care in England. So essentially trying to implement a framework. I think I'm going through some of these examples also because some of the things I talk in workshops and in my sort of case studies would be based on some of these projects. The other is really interesting. You might have heard of or conceptually relate to sort of friendship bench intervention. We were talking about it yesterday. It's essentially grandmothers sitting on a friendship bench based in a primary care or community setting, providing sort of psychoeducation or sort of behavioral activation sort of strategies. It's been proven to be really clinically effective. And so we're trying to take that intervention, take it to South London in England, and trying to roll it out for South Asian women. So that's also sort of, we've done some initial scoping work and interviews and stakeholder consultations, where we're still to sort of materialize what it looks like for South Asian women. We're hoping to sort of address anxiety, depression, distress in these communities through that project. Okay, so I think the other project is diabetes and distress. So essentially, how can you manage diabetes, distress, which is very different from diabetes and depression in clinical settings. So that's another sort of project that I'll be referring to in my talk today and over the week. Okay, so this was all to say, well, if you really need to know what in implementation science is, I think you need to understand the kind of people that work in the field. So people like myself. So you could be, essentially you could be anyone and just sort of trying to answer the same question. How do you roll out a clinically effective intervention? So you have health economists working in implementation science, you have physiotherapists, you have other clinicians, you have social workers, you have anthropologists, you also have geographers actually doing geographical information systems and sort of working in the field. So you could be anyone and interested in answering the same question: why does an intervention fail? So I'm not sure, we had a webinar before I came here, and some of you might have attended, and we went through some of these concepts, but I thought it'd be nice to do a recap. And I'm really sorry for those who attended, and this might be a repetition in that sense. Scholars have argued that implementation science is more of a sort of a complex system than a complicated system. I think we often confuse or think they're both the same things, but complex systems are essentially more sort of iterative. You don't know what to expect. So authors have argued that implementation science is more of a complex system, which is kind of like raising a child than launching a rocket. Oh, sorry. So when you're taking the intervention for rollout, you really don't know what to expect in the context. But so it's more like sort of raising a child. Having said that, I only have a dog. On the other hand, launching a rocket is more in tune to sort of precision. So if you follow the steps, you can actually get through. But in a complex system, you really don't know what to expect. So that's another sort of way of looking at what we are dealing with and how sort of challenging that may be. And scholars have also argued that there's no other system as complex as healthcare. I know that there are people from sort of business physics background, they might disagree, but this is some of the what scholars have said. Okay, so how many of you know what a surgical safety checklist is? Yeah, I see a few nods. I see people a bit too shy because there's a mic, or? Okay, so that's a sort of a comprehensive checklist that was developed around 2008. It tells you it details what things you need to check on a patient before, during, and after the surgery. So things like ensuring you're operating on the right site, for example, ensuring that antibiotic prophylaxis have been provided in time, because there's a sort of criteria for when that has to be given. So things like that. So this checklist was developed in 2008. And there were 8 pilot evaluation sites across the globe. And these are these sites. And a really sort of impressive publication came in New England Journal of Medicine. I think that's second to God for us in sort of healthcare. And what they found is the checklist massively reduced morbidity and mortality. So the complication rate decreased by 36%, but mortality decreased by almost 50%. And so did the post-op infection rate. So that was sort of a monumental publication. And just when this was out, alerts were raised. So yeah, the WHO estimated that 500,000 deaths could be prevented by rolling it out across the globe. Again, that was a sort of an impressive figure. And within weeks of this publication, patient sort of alerts were raised, and everybody was told to roll this out without any sort of support or training. But what happened? Sometimes what you think is work as imagined is not work as done. And the The subsequent studies actually failed to show that same success rate. So much so, there was hardly any difference in the mortality rates pre and post checklist implementation. And they said, oh, what was going on? So some people in my group, oh, it is stuck suddenly. Oh, yeah. Okay. So there's some of my colleagues, we tried to study this qualitatively. So what was going wrong? And these are some of the quotes from the stakeholders we interviewed. And I want you to sort of briefly go through them and sort of read them in your own time. Any reflection? Does that resonate with what you do? Yeah, I could see the notes. Anybody wants to? I'm really happy to make it sort of more interactive. So if you have any thoughts from your own area of work, have you ever come across instances where you've been given a checklist, or you know others have been given a checklist and the rollout fails? Yeah? Or you've been given training to, I think that must be something that you must have come across. You've been given training, and then when you go to your practice, you realize, oh, that doesn't really work. I don't have the time. Yeah? Yeah, okay. A few nods there. Okay. So there's an intervention or an innovation. Intervention, we try to see if that's clinically effective. I'll try and go through these words after next few slides, but what we're trying to understand is, was there anything wrong with the checklist? Or was there anything wrong with the way we were delivering or implementing the checklist? And these are two very distinct things. So again, I'm going to repeat that. Was there an intervention failure? Or was there an implementation failure? And in implementation science field, we're trying to address the latter question. Was that an implementation failure? We can study implementation before an intervention is clinically effective. For example, understanding barriers and facilitators to implementation. But primarily, implementation should be studied once the intervention is effective. I'll tell you an example. I think that might be helpful. So there's a program called Serenity Integrated Models in the UK, which was rolled out at a national level. Essentially what the program does is it's for highly vulnerable cases, people with sort of suicidal risk or harm. And police officers were made to sit in the healthcare facilities. That led to a lot of discrimination against the patients. So the patient groups or the advocacy group, they all came together and said, well, this intervention should be stopped. It is actually having more harm than good. They went to this then CMO Chris Whitty, the patient groups, and they said, well, you really need to stop this intervention. And there was a thorough evaluation done, and they found out actually there was actually more harm. So the mild depression cases increased to moderate depression on a PHQ-9 scale. That's how they sort of assessed the outcomes. And it was then sort of banned across the country. So why I'm saying this example is, well, you cannot assess implementation unless you have holistically proven an intervention is clinically effective and safe for the patients. However, increasingly so, funders are very keen in understanding barriers and facilitators to implementation before an intervention is clinically effective. So you'd see a lot of calls in NIH and NIHR, the two sort of funders that we work with. And I'm sure it's the same here as well. So again, moving back, there are quite a few papers on assessing effectiveness of implementation. And our colleague, Jeff Kieran, who works with us on a few sort of short courses that we deliver at King's, he came up with a seminal paper on combining clinical and implementation effectiveness. again, sort of focus being, his focus being more on both clinical and implementation effectiveness. So what is implementation effectiveness? It's like essentially a function of clinical effectiveness plus implementation factors. I feel like I need a board here to sort of scribble this, but we'll try and arrange it. Okay. And this paper by Zoe Morris, was again sort of really popular at the time. I'm hoping this figure has sort of now changed. Okay, so I was talking about how long does it take for an intervention to come from a shelf to actual clinical practice. And they calculated it across different public health programs, and they find out that it was 17 years. You can sort of have access to these papers using scanning the QR code should you like, but you'll also have access to the slides, so you don't need to jot down anything. So 17 years, can you imagine, like, as a health and social care professional, you work on sort of basic science research, clinical research, efficacy research. Even that takes forever to develop. And then trying to roll that out into actual clinical practice, and how different things are at the coalface. So I wasn't surprised, because when I was working after my master's in the field, I did see that gap, and sort of some of the common elements I saw, at least at the time, was how important it is to speak the language of a policymaker if you are trying to sort of sell your intervention to a policymaker. We were in sort of south of India and Nepal, and there are some professional cultural hierarchies that you have to respect, even though you may sort of disagree or agree with them at a personal level. So all those nuances are really, really helpful. Yes. And could I please request you to just say your name when you ask a question, and also say where you work, so that I can get to know you?
Oh, that's quite loud. Hi, everyone. So my name is Muchizi Mrondo, and I am part of the Division of Public Health here at the University of the Free State. And so I'm actually just curious about that number. And wondering, did you find that it was quite different whether or not it was at a lower middle income country compared to a high income country?
Yeah, it's an excellent question. So again, this was more at a sort of a high income country level, because the publications they gathered mostly came from high income country. So obviously these numbers are very sort of, they have to take in with a pinch of salt, because it might be very different in the context. Do you think the number would be more for LMICs? Yeah, I think so. Yeah, but that's a sort of a good piece of research coming maybe for this faculty to see if it's specifically for South Africa, how high is the number. And this is an old publication. I'm hoping the field has been there for 10, 12 years, so there has been a change. But yeah, I'm happy to be sort of surprised as well. Yeah, but this was more high income focus. So Butler actually said trying to implement an intervention is kind of like crossing the Death Valley, and you often sort of fall in between the gaps. And that paper came out in Nature. So this was all around the same time, 2008, 9, 10, where the field was sort of getting traction. And hence, people realize that we do need to work on a science of implementation. So science to understand the factors or determinants of implementation. Science to understand which theories, frameworks, and approaches we need to sort of embed implementation principles. Science to improve implementation. Science to improve quality improvement. Science to improve evaluation. And science to explore relationship between implementation effectiveness and clinical effectiveness. I would say we've been able to work on the first sort of 3 factors, but I think we are very far away from understanding the sort of causal relationship between clinical effectiveness and implementation effectiveness, and that's an area of research that is up and coming. And WHO says all the time that there's so much research sort of waste happening. We collect a lot of data, we do a lot of research, but it doesn't get rolled out, that they say you cannot improve patient care if you do not invest in sort of understanding implementation. So here I am trying to make a case for implementation science, but you don't have to necessarily agree with me. And I would be sort of happy to be sort of challenged by you on otherwise. Okay, so this was essentially to sort of take a 5 minutes coffee break. But if you're doing okay, maybe we can sort of continue. I think I would like to know who's in the room. One of the major sort of, it's not a eureka finding, but finding of implementation science is building stakeholder relationships. So I think it's really important. I've tried to tell you a bit about myself, where I come from, where do I work, and sort of where I'm clinically trained. But I think I'm really interested in knowing who's in the room so that I can sort of carve some of the examples. In the next few slides, we will understand basic concepts of research. And I'd like to know who is working in research for sort of how many years, just to get an idea of that, if that's okay. And I'm going to start with you, Fiti. Do you mind giving an introduction and for how long you've been working in research? Okay, all right. Let's start with the audience.
Good morning. My name is Pax Mahwali. I'm the associate professor at Central University of Technology. I did my master's here in TB at the Faculty of Health Sciences. I'm mostly in the medicinal plants research, in disease surveillance and resistance monitoring. I'm the lecturer in microbiology at CUT.
Well, that's quite a few roles together, but yeah, well done.
Morning, colleagues. I am Dr. Nkosi. I'm a clinical epidemiologist and also a co-supervisor at Division of Public Health. I'm not really that much experienced in research. I think I've now plus or minus 3 years in research.
Okay, that's helpful. Thank you.
Thanks.
Nice to see you.
Okay, I'm Debuho Mhlanga from the Department of Health. I'm a physiotherapist by profession, currently running rehabilitation services in the district. I am studying rehabilitation studies with the University of Stellenbosch, and I've got bitten by the research bug. I think from now on I'll be embarking in a lot of research, and what sparked my interest in implementation sciences is that very gap that I realized that there is a big gap between practice and research. Hence, I gave myself a name, a pracademic, because that's where I'm going to work towards, because that's my interest, to close that gap. Thank you.
Thank you.
Good morning. My name is Thala Deu. I'm also from the Department of Health. I'm working at Mangau Metro District Office, and I'm responsible for quality assurance. So I'm more on the implementation side. Regarding research, not yet there. I'm still trying to figure out and interested in starting to do research next year. I'm a professional nurse. Thank you.
Thank you.
All right, good morning, everyone. My name is Khotso Musitwani. I'm working for Right to Care, of which is a district and provincial support partner to the Department of Health. I'm currently based in Thabo Mofutsanyana district. I'm responsible for the community component, and professionally I'm a social worker. And I'm currently on the ground doing the implementation work, not so much involved in the research component, but we do have some of our colleagues online, of which are more inclined with the research component. So yeah, they will introduce themselves as well. Thank you.
Thank you.
Hi, I'm Mariette de Beer. I'm a lecturer's assistant at CUT. I work in the Faculty of Health Sciences and with clinical technology. I'm a clinical technologist. And I'm basically just busy with my master's. I love research and the implementation of it, because sometimes it feels like you do this amazing research, but nothing happens with it. So, yeah.
Thank you.
Morning, I'm Tsakovato Labani, and I have a background in medical physiology, but I'm just at the early days of my research, so I'm doing a master's in pharmacology, specializing in traditional medicines.
Hi, my name is Ngubile Hatewe. I have a background in chemistry and microbiology, but I'm doing honors in pharmacology in UFS.
Good morning, everyone. I'm Rosa from the Department of Pharmacology. I'm a postdoctoral fellow. I'm a chemist by profession. Thank you.
Good morning again, colleagues. My name is Mochidze Mrondo. I am a lecturer here at the Division of Public Health. And so I've got my background or my PhD in health sciences education as well as in community health, but also a master's in psychology as well. So I was very interested when you were touching a lot on mental health. And so I supervise our master's and PhD students here. So I'm also very interested in research and learning more about implementation science. So thank you so much.
Good morning, everyone. My name is Cindy Somontuedi, and I'm an administrator in the Public Health Division, UFS. I am currently busy also with my master's degree in HR at University of CUT, in fact. Yeah, that's about it. Thank you.
Morning, colleagues. My name is Sipho Zulu. I'm based in the Faculty of Health Sciences as a research coordinator. I'm also writing my PhD in parasitology, and that's where my interest is, human parasite.
Hi, I'm Ngita Kusu. I hold a PhD in biochemistry, specialty of molecular pharmacology. I'm postdoctorate is in the Department of Pharmacology. I work on diabetes and its complication, specifically the management of this disorder based in plant. Thanks.
Hello everyone. I am Dr. Chinda Fosi Sedik. I am postdoc in Department of Pharmacology. My background is the biochemistry. Now I work in the cancer, prostate cancer, with how to investigate the activity of cannabinoid in the spheroid. Yeah.
Good morning, everyone. My name is Tabiso Eminatim Tetwa, and I have background in the medical science physiology, and I'm currently doing honors in the Department of Pharmacology.
Good morning, colleagues. My name is Dr. Anand Krishnan from Chemical Pathology as a senior lecturer for research. Recently, I moved to Division of Public Health. Now, actually, I'm a pure laboratory researcher. I'm professionally chemist. I did my PhD in synthetic chemistry, then my postdoc with the medical biochemistry. Then I work with NHLS as a clinical biochemistry. Now, then I appointed as a senior researcher for chemical pathology. My research is totally interdisciplinary: chemistry, nanotechnology, now clinical diagnostic. We try to develop a point-of-care test research platform, especially for cancer, brain injury, and pregnancy women like a preeclampsia, stillbirth, to try to develop nanotechnology. By using nanotechnology, try to develop point of care test for early detection of disease. So it's a fully experimental. Apart from diagnostic research, I'm doing some collaboration with different colleagues from my collaborator here, like a nano drug delivery by using exocells vesicle, exosome, and stem cell research also we doing. So there's so many project I'm handling. I have 2 PhD, 1 postdoc, and 2 master, and then I'm running one research group. Very recently, I joined with the public health. It's a new platform for me, but really I feel like before I start laboratory research, I have to learn public health because both is, now I'm learning how to incorporate public health to my laboratory research. Because the laboratory research is a lot of, as a scientist, laboratory researcher, we don't know about public health. Now I understand public health is more important. We can take some concept, we can incorporate the laboratory research, we can bring it more accuracy for a health society. So I'm going to do soon with my team. Yeah. Thank you.
Thank you.
Morning, everyone. My name is Tibojen. My background is basically in natural product chemistry. I specialize in isolation of compounds from medicinal plants. I work in pharmacology as a lab assistant.
Good morning, everyone. My name is Dr. Ngui Mulu. I am a postdoctoral research fellow at the Center for Health Systems Research and Development. I'm from the humanities, so I was happy when you said anthropologist. I also welcome in implementation science. The reason why I'm here, my background is in sociology of health. So the reason why I'm here is because I'm currently working on an intervention. We are adapting a program called Program P, which was originally developed by an organization called Promondo. It's now called Equimondo. And throughout my postdoc work, we are trying to adapt that intervention, that program, which is designed to promote male involvement in maternal and neonatal health to the context of Sesotho-speaking communities in the Free State. So it has been quite an interesting project, and we are adapting the manual. So what I learned from this would help us for how we take that forward in terms of implementation. So thank you.
Good morning, everyone. My name is Rachel Oliphant. I am also from the Department of Health, Mangaung Metro Health District. I'm responsible for the HIV prevention program. We are having so many projects that are implemented, but our major challenge is the implementation thereof. We start a project, but along the way it will, die a peaceful death. So I'm hoping that this training will sort of nudge me and give me some skills so that I can go back and implement at our district. Just for a short brief, we have a project that we are focusing on screening and testing the 5 to 14-year-old children. We are missing them because they are not accommodated by our screening tools at our facilities. So we are having sort of pilot facilities that we've started doing that. So I am so happy that I'm here. Maybe I'll come up, with skills or intervention project that will make our implementation to be sustainable. Thank you.
Thank you.
Hello, everyone. My name is Anisia Pamudze. I work as a HIV/TB clinician in Lesotho. I'm a Master of Public Health student, so I'm here because I need to learn how to incorporate the implementation into our research projects we're doing currently.
Good morning, everyone. My name is Happy Page. I'm from Central University of Technology in the Department of Math, Science and Technology Education, with a keen interest in physics education, and as well as now science communication, which diversifies into now the STEM education, whereby now instilling now whatever now is being practiced in academic world, industrial world, how do you make it reachable to the communities, how they can become aware, they engage with now their daily lives, how do they engage with science, how do they practice it, how do they get inspired, especially youths at school levels, to ensure that now they push now careers in the science, technology, engineering, mathematics, and innovation. Thank you, colleagues. That's my question.
Thank you, colleagues. Lebogang Mokgongwa from the Central University of Technology in the Department of Health Sciences. My profession is as a medical laboratory technologist. So, and then from there, my background is mostly in hematology and immunology. That's where my research focus has been. But now, recently, I've been trending into public health to see what we can achieve with a doc over there. Thank you.
I think I like to be mobile, so this is better. Okay, thanks so much. Very cross-cutting themes here. Definitely a very diverse sort of group, which means, which chimes with implementation science in the sense it's all about sort of multi-professional care and multidisciplinary care. So that's, I mean, we've always seen sort of social workers. Some of the actually theories in implementation science were developed by sociologists and social workers. I'll talk about them briefly. And yeah, I mean, we always sort of try and pivot to different disciplines, and we don't sort of leave our initial understanding of sort of biology or biochemistry, chemistry per se, and then we sort of try and incorporate that. So it's more than the sort of well, that's okay. Yeah, so it's more than what we learn in individual sort of subjects. So I think that's one observation from this group. The second is I think you're all experts in your field, and I might not know the sort of nitty-gritties of your field. So that tells me that we both are experts. We means I and you. So I would like our conversations to be more on a level playing field, and sort of for you to sort of be empowered enough to feel that you are definitely the experts, and we sort of share those conversations in that sense. So these are some of the principles we will also embed in group working. First of all, respecting sort of other person's expertise and understanding the role of interprofessional care and multidisciplinary in research. So the third thing I wanted to say is I would be very happy if you want to get a drink, get a coffee and sit, as long as it's not hot food and I feel tempted. I'd be very happy for you to sort of walk around, have a drink, and take it sort of little more sort of informally and casually. Okay, and I didn't see anyone get up. That's okay. All right. Okay, we'll try to, looks like there is some understanding of research. Some people work in epidemiology, some are starting to work in public health. A few of you are MSc, PhD students or postdocs and might have sort of come across some of these words. Okay, this is a Cochrane ladder of evidence. Can you tell me, let's go from the bottom of the ladder. So essentially this is a policymaker or, there's an organization called National Institute of Health and Care Excellence that creates or recommends evidence to the NHS. So this is this that's called NICE. So that's a NICE professional on the ladder. And he is standing on the efficacy ladder and saying, well, look, I can see all the evidence from here. And the lady on the floor seems to be, I'm hoping, surprised. Okay, so I want to ask, what do you think efficacy is? And no answer is a dumb answer. I would really want us to sort of learn as a group. Because it took me years to sort of kind of understand some of these differences, and I think it's good to be on the same page with definitions. It might not be as sort of written somewhere, but just some understanding. What does it mean to be, for an intervention to be sort of not effective, but what does it mean to be it to be more sort of effective in a sort of a non-homogeneous sense? Let's anybody, efficacy. Okay, let me give an example of efficacy. Okay, blood glucose monitoring. It's an intervention. But when this was developed, how would they assess the efficacy? I think some of the basic sciences people in the group or clinical researchers might be more familiar with it. Anyone? Efficacy? Okay, throw anything, and then we'll try and see how we can. I know you're all experts. When all the experts sit in a room, they are relatively shy. So I'm teaching civil servants in the UK, and I teach MSc students. And it's the same course, so we're teaching a very similar course, health systems research and implementation research. The MSc students, they are so curious. The civil servants, they work in Department of Health and Social Care, and they are sort of full-time professionals, and they're doing this masters along the side. The civil servants, they're so apprehensive and they really don't want to show that they don't know to their other colleagues. And it has taken me almost an year to let them to sort of, start discussing and sharing their ideas. Anybody, efficacy, anything would be a good answer. Yeah, can this be done? Yeah, that's the boundary we're in. So can this be done? And this here is an intervention. Sorry. Okay. Yeah, that's very helpful. Thanks so much. Can this be done? Can this be done in a laboratory setting or in a controlled setting would be sort of the next add-on to the definition. So essentially, we're trying to look at interventions that are proving to be effective in a controlled setting. So not necessarily vacuum, but in a controlled setting. So when they would have tested the blood glucose monitoring machine, CGM, for example, they would have done that first in a clinically controlled setting. Not clinically, controlled setting. Yeah? So efficacy is, can you give me an example more for efficacy? Anybody can think of any intervention that has been tested in a controlled setting? Any example for the field that you work in? Okay. For example, the other example I could now think of is cognitive behavior therapy, a type of therapy that was, when it was first developed, it was given to sort of a highly specialized group of patients, but not in a clinical setting, but in a sort of controlled room. So you always try and see if an intervention is effective in a controlled environment, and then you try and see if the intervention is effective in an uncontrolled environment, which is clinical effectiveness now. Yeah? So, well, you go to a hospital and test the use of continuous glucose monitoring. So that would be more of a clinical effectiveness study. You do sort of randomized control trial and cluster RCT. And the clusters are generally a group of hospital, or a cluster is a group of ward. So that's clinical effectiveness. And then comes cost effectiveness. Bless you. So the sort of costs it is saving to the NHS for us in our context. Yeah, it is actually cost effective or not. For example, the cost of appendectomy in the UK a few years ago in a private hospital would be £8,000. On the other hand, you could provide at least 2 children with the full sort of private school education up until GCSEs or A-levels. So how do you sort of prioritize one intervention over the other? I think you really need to know the sort of cost. And we'll learn a bit about cost and cost-benefit analysis in the sort of coming days. So what is the sort of, you could also immunize 2,000 children. So would you actually do one appendectomy, immunize 2,000 children, or give primary education or secondary education to 2 kids? So how will you choose? Which one will you choose? These are sort of really hard prioritization decisions, and there are different criteria of prioritization we use when we are selecting one intervention on the other, or over the other. And this is very much dependent on the health system context. For example, if I'm correct, NICE, the organization that develops evidence or recommends evidence, it doesn't develop, everybody else develops, and they say, well, we recommend you give cognitive behavior therapy to people with moderate depression, for example. Recommendation 5.0. Okay. The other thing, so yeah, I was talking about sort of prioritization. So NICE prioritizes if any intervention costs below £20,000 to the NHS for an X number of population, then they don't take it out. They don't think that's cost effective, because you have to put a mark somewhere. And that's how some of the priority decisions are made. And you need to do sort of cost effectiveness and cost benefit analysis. So yeah, this gentleman on the stair, he thinks if he's just seen efficacy evidence, that's enough for them to make a decision on what to take forward, which is not necessarily the right thing. I think I'm going to add another ladder, another step on the ladder, and say implementation effectiveness. If the implementation rollout is so expensive or so difficult in a different context, do you actually want to implement an intervention? There would be sort of various schools of thoughts. So if the intervention is really improving patient and service outcomes, and the implementation is not well thought of, then it could still sort of fall at the coal face, and we'll see how. Okay, we now understand efficacy, effectiveness, cost effectiveness, and we'll try and see implementation effectiveness. All right, I'm not going to go into knowledge mobilization. Anybody works in the area of knowledge mobilization? So if you start working in public health, you'll see people working in more so in clinical effectiveness, less so in efficacy research. And then you see people who try to take that evidence, clinical effectiveness evidence, to the sort of policymakers, providers, and other stakeholders. So that's called more knowledge sharing. Now the term that we are using is, and it's really dependent on where you are. Canada uses knowledge transfer. In the UK, we use the term knowledge mobilization. So essentially, you're saying that you're sharing knowledge with stakeholders throughout the research cycle, when you're designing, when you're implementing, and also, of course, when you are sort of at the end stage where you're ready to disseminate to different stakeholders. So it's really important to understand knowledge mobilization is more around push and pull. So mostly, traditionally, we have used knowledge mobilization once the results of a study are out, and then you take it out to different stakeholders. That's more knowledge sharing. So it's more the push. And the pull is when you are pulling knowledge across different stages of the research cycle. So this is so sort of recent that we are, so I work with the funding organization as well, 1 day a week, National Institute of Health and Care Research, and we're trying to de-jargonize or sort of rephrase some of these terminologies. So we'll be using this knowledge definition from next month onwards. It says it's the process that paves the way to impact, being realized by actively bringing stakeholders together throughout the whole research cycle to share, respond to, and act upon research plans and finding. So the idea is to have a higher impact by not only disseminating towards the end of research cycle, but throughout the research cycle. Some of you said you work in implementation. Can you give me an example? You said you work in implementation. What are you implementing? Okay, so it's a prevention intervention. And obviously that has been tested somewhere, clinically effective somewhere. The prevention strategy, it came from, who's the funder? So.
Basically, the whole idea is from our National Department of Health.
Department of Health, okay. So that's good, you're not ruling out a prevention strategy that was developed somewhere in Texas. So you're sort of developing a prevention strategy was developed here. So it's more contextualized. So yeah, the practical process of delivering interventions would be implementation. And the practical process of integrating new practices or products, it's even products. I think when we talk about interventions, we generally forget medical products. But that's again one of the health system component. And it's when I talked about continuous glucose monitoring, that's more of a product. So that delivery of that in a practice would also be implementation. We generally do a lot of debate on what these terms are, but I think we have to get through a lot, and then we'll sort of move along. Okay, so in terms of definitions, I like these two definitions. There are multiple definitions of implementation science. So Mittman, one of our colleagues, he says, and there's a journal called Implementation Science in Biomedical Central Journal. And he and his colleague Eckleeks defined it as the scientific study of methods to promote systematic uptake of research findings, clinical research findings. So just slowly reading it, it's a scientific study. I think it's more of an art than a science, but we can debate on that. So it's a scientific study of methods to promote uptake of clinical research findings. So here it is saying that it's more about clinical effectiveness and evidence-based practices. I gave you an example of how once police was involved in sort of delivering mental health interventions and then didn't go well. So that interventions eventually was found out was not evidence-based, was not co-produced by members of the public. And we're trying to do that in routine practice. So this is a kind of research study which is essentially focused on sort of practice. Instead of, you can't do it without sort of involving different stakeholders, with a view of improving quality and effectiveness of health services. The NIH definition is more broad, and I like it in the sense that it says it is supporting innovative approaches. So innovative approaches, there's a innovation and intervention. What is the difference between innovation and intervention? Different school of thoughts. Here they have kind of said innovative approaches are interventions. Where I practice in the UK, for us innovation is more efficacy, but not necessarily clinically effective. How would you see innovation and interventions in the South African context? Or these words are used interchangeably, maybe? Yeah? So it might be that these words are used interchangeably. NIH says implementation science is trying to support innovative approaches to first identify then understand, and then overcome different implementation outcomes. So adoption, once you just enter a clinical practice, that's adoption. Adaptation, how you tweak the intervention or innovation according to the context. Integration, how do you integrate it with, for example, already existing policies, electronic health records, for example. And then how you scale up and sustain. Very heavy terms, and I think implementation scientists had all the time in the world, and they have tried to sort of define, come up with different theories, models, and frameworks to understand all of these words. And yes, I think tomorrow we will be discussing some of these terminologies and how they are measured. Some of this is very intuitive, but I think they're conceptually sort of very distinct. They might sound very similar. For example, scale up and adoption, scale up and sustainment. But implementation scientists argue that these are very conceptually distinct terms, and there are different ways to sort of qualitatively and quantitatively measure these, which we will sort of cover. Essentially, we're trying to nest a clinically effective intervention into practice. That's what implementation science is about, and we try to study it through sort of a scientific lens. Yeah? Okay. Okay. I was talking to Findy yesterday, and I thought it'd be very helpful to add this. Some of you might work at the interface of policy and practice. So this is a triangle. One vertex of the triangle is research. One is practice. Implementation science, when it developed last 2008, around that time, most of the research has focused on this trajectory. So from research to practice, yeah? There's something called as policy formulation and research agenda setting. So that's from research to the other vertex of policy. Very recently, there's a field that's emerging. It's called policy implementation science. Because we have all the time in the world, we thought we need different methods, again, theories, frameworks, and strategies to understand how a policy is implemented into practice. Sometimes the time taken from research to policy is very quick. And then you see things failing at the coalface, at the practice. Why we have thought of having a sort of a triangle, we think these three vertices should be sort of equidistant from each other. Essentially trying to say you need to invest time in agenda setting, policy implementation, and implementation science. Any questions? Why did I think you'll have one? Yes.
Well, I'm not sure if I will ask clearly, but just more keen on consultation of all stakeholders before the policy is implemented. So I would think that it's more important during research when the agenda is being set. In case of, I've seen the other slide on knowledge sharing and everything, in order to integrate the knowledge that we have in our communities, to be part of the knowledge that is scientific from academics, and also what the policy implementers expect. And then other stakeholders, maybe in industries, for instance, how does one integrate that knowledge? Because you may find that what exists in communities at times is not considered as evidence or existing in the scientific world. But again, it does influence the uptake of policy, once it's implemented, and everything that needs to be done by the beneficiaries or whoever the policy is meant for. So how would you stress the importance of integrating that knowledge during that stage of agenda setting and research? And bearing in mind that when we design our research studies, we sit down as academics, think of the questions to ask communities. We look at maybe previous questionnaires, if you're using a survey, how you will adapt that, and the communities are not there. And that is when you go to them with that tool, but they had no input whatsoever, and you have no idea what exists that cannot be captured through the tools that you are using while conducting research. Thank you.
That's such an important question. I'm so glad you asked that. Okay. And there were a few questions in it, and I'll try and sort of bifurcate and see if I can respond adequately. How many of you have heard of the evidence hierarchy? So at the bottom of the hierarchy is sort of personal views, and there are different study design, like cohort case studies. And at the top of the hierarchy is a randomized control trial and cluster control trial. No. At the top of the hierarchy is systematic reviews, and below the systematic reviews, you have randomized control trials. So that's the sort of strength of evidence. So at the top of the triangle, the evidence strength is the most. This was a traditional concept of seeing evidence. More recently, as you were saying, evidence is more blurred if it doesn't include voices of the people it is affecting. So essentially, now we have an area of work or field called PCIEP. So it's patient and carer and public involvement, engagement, and collaboration. Collaboration is when you work sort of closely on a day-to-day basis. We've seen involvement, which is more tokenistic. So what at least NICE, the sort of evidence generation body in the UK, is trying to say is evidence is incomplete without involving or co-producing the evidence with the public and different stakeholders. So if you look at research, now the key funders, they don't fund research unless you have a dedicated budget for involving, collaborating, not involving, with patients and service users and members of the public. So we're trying to address your point of sort of co-producing evidence right at the start of the research cycle. Even in efficacy study, now there's a requirement, and rightly so, to sort of involve patient voices here. And then it doesn't only stop here, because you can actually sort of you would involve 10 patients, but that might still not be the view of the entire community. So there are multiple stages where we involve patients. So we'll involve this at research, and then before the policy is formed, you'd ensure there's a sort of a policy working group. In the projects I worked in, we have seen how first time a mental health policy was developed in a few countries, and we had sort of activists, advocates, and members of the community organization involved in the agenda setting and policy formulation. And then it doesn't stop there. During policy implementation, you also need to have those sort of stakeholder group and sort of ensuring voices are heard. Because it might be that, for example, the evidence that, the intervention I talked about, SIM, Serenity Integrated Models, that involved police to manage mental health of patients, vulnerable, highly vulnerable patients. That research showed that worked, and it was quickly taken up, made a policy, and during practice is what we found out that it was actually not effective. Why? Because practice also involves, practice research also involves community organizations and members of the public. So it's really critical, and I mean, you'll still see, and you won't be surprised, and I'm sure you have examples that co-production has still failed, even though we've considered this at all the 3 stages. And you were talking about the sort of the smoking cessation sort of work that you've been involved in, how co-production still falls between the cracks, and yeah. Anybody can think of sort of co-producing research and how that has not being effective at the coalface? Or does some of this resonate with your sort of area of work? Yeah. Okay. So I thought it was very important to say, look, implementation science started with this, but it's now also engulfed, so to say, policy implementation science. Yeah.
Yeah. Okay.
Sorry, you had a question.
Okay. Yeah, in my field, what I've noticed is that there are policies and guidelines that have been developed at national level.
Mm-hmm.
And what I've noticed is that they have not been implemented or fully implemented. Actually, the other one that was recent, the 2015 one, which was given a 5-year period to be implemented fully, has not been implemented as yet. So I'm trying to figure out what could be the reason that we've been able to move from research to policy, but when it comes to implementation, it's not happening. Nothing, like 10 years has lapsed and there's no implementation. So I'm just thinking that is it probably because of not engaging with the stakeholders, or maybe that during this especially agenda setting phase and policy making, that maybe all the stakeholders were not involved. As a result, when the policy was rolled out, people who were supposed to implement didn't implement, you know. So it's quite interesting for me now that I look at this triangle, that I look back at what we've been doing and I realize that that's the problem that we are facing right now.
Yeah, I'm very pleased you said that some of these frameworks, they can sort of springboard discussions. So they're not set in stone. These sort of structures are just a way to start a discussion like this. So I'm really sort of pleased you said that this instigated the thought in you. Coming to the sort of actual response, there could be multitude of factors that have led to failure of implementation of the policy. And in implementation science, we'll try to comprehensively look at them and see which of the strategies, for example, you talked about stakeholder engagement. So that's a very common strategy. So we'll try and see which of the strategies worked and where there's room for improvement. I'll give you an example. So we were trying to roll out mental health policy, which was accompanied by a mental health plan in India. And we were doing it at a provincial level. They call it state there. So we were in the central state of Madhya Pradesh. And most of the times you think there's less budget to implement. You know, that's why the implementation is not happening. Implementation field is arguing, even if you have the resources, you might still fail at sort of the coalface. You might still fail to implement effectively. So I clearly saw that example. So at a state level, I found out, at a national level, they said very little money is allocated to mental health, 1% of the health budget, there should be more. So that's what we were arguing. At the state level, from last 3 years when I was working there, there was underspent in the mental health budget at a provincial state level. And I was amazed. Because initially I thought it's always money, you know, you give them money, you can hire people, you can get the work done. But it wasn't the case. There was underspent. They really didn't know how to technically support primary care to deliver mental health services. So that was the issue. And there were, obviously, workforce was an issue. It was always difficult to sort of request for new posts. But even though there was some workforce, so there were psychologists, psychiatrists, and there was a plan, but there was nobody to sort of support a health system. And sometimes you see these sort of these sort of bilateral organizations or funders, they'll come in and, for example, Gavi would come in and they would provide technical support. So we realized in that state, the issue was nobody understood the mental health system and how to provide the support. Nobody knew that you need to collect data on basic mental health indicators, for example, procurement of psychotropic medications. Yeah. And so we were able to recruit someone in our project and then argue with the policymakers and planners at the state level that, look, you have an underspent budget. If you hire somebody like this person, they will be able to manage, sort of provide technical support to the psychologist, psychiatrist. We were trying to train nurses to sort of do early detection for depression. So they'll be able to support with that. They understand the supply chain system, they understand governance, they understand information system, and so on and so forth. And they saw us rolling that out in the research project. And the government saw the value. And once we left, because we had funding for 5 years from European Commission, we left. But they saw the value of that person. And the person also was somebody from the community. So they could sort of relate with that person way more than us sort of parachuting from UK and trying to tell them what to do, where they actually already knew, this person already knew what to do. So this person was then made a permanent sort of employee within the state services. And there's a mental health cell in primary care or a space where nurses would go and sort of diagnose patients with sort of depression, psychosis, and alcohol use disorders. And then we created a referral pathway to secondary and tertiary care. So yeah, there could be multitude of reasons. But here we're trying to understand what's the breadth of those reasons. We don't want to miss any reason. There was one reason, what she talked about, Findile, co-production, co-producing evidence with sort of relevant stakeholders, patients and members of the public. But I'll pause there. Let's have a tea break for 15 minutes. Okay, so we have a proper tea break for 15 minutes now. And please stretch yourself. As a physio, I'd highly encourage you to even stand at the back of the room and listen, should you like. Have a tea and we will continue. Thank you. actually looking to develop reliable strategies for improving health-related processes and outcomes, so coming up with new strategies to strengthen implementation. Also produce insights on implementation, understand the process, understand barriers and facilitators to implementation. The third sort of aim is to essentially evaluate implementation. So test and refine implementation using different theories, frameworks, and models, which we will briefly go into detail now. Okay, so we talked about efficacy research, and we talked about effectiveness research. So efficacy was more around intervention being tested in control settings. Efficacy research is more on uncontrolled testing interventions in an uncontrolled clinical setting. And then spatially speaking, this is where implementation and hybrid implementation designs, which we'll discuss, I think, day after tomorrow, fit. So it's once you've established, as I said, once you've established the sort of clinical effectiveness, that's where you start studying implementation. Having said that, I'm currently involved in a project on diagnostics. So we're trying to develop, somebody who's talking about point-of-care tests for bacterial or viral infections in the emergency department. So there are new technologies coming up, and it's more of an efficacy research that they're doing at the moment. But the funder said, well, you need to think about implementation right at the efficacy research. So you I'm sort of contradicting myself here, but you should test implementation only once you've tested clinical effectiveness. And although you can understand some of the pre-implementation barriers, facilitators at every level of this sort of research cycle, the idea is to sort of eventually improve healthcare processes and sort of patient service level outcomes. I do realize that I forgot to mention previously, we have people online. So if anybody would like to sort of clarify concepts, share some reflections, we have our colleague managing the chat. So please feel free to drop in a message, and I would be very happy to take that up here. Okay. All right. These are the implementation research terms. And the idea would be by at least end of tomorrow, I would want you to sort of get an understanding of these terms. And we will briefly go into detail about these as well today. So implementation strategies in lay terms, I'm not going to go into the definitions, we are dealing with the definitions tomorrow. But implementation strategies would be, I think our colleague here talked about stakeholder relationships, and somebody sort of mentioned co-production. So those would be the strategies. There are different strategies. People have done research into trying to understand the breadth of implementation strategies that have ever been used. It could be things like financial incentives. It could be things like involving consumers. Audit and feedback is also a type of implementation strategy. So that's where spatially this word fits in. I mean, I think most of the time when I work with clinical effectiveness researchers or efficacy researchers, they all want to involve implementation science principles, but they get bogged down by these jargons. And when you try and speak to policymakers, planners, or even consumers, patients, and members of the public, we just lose them when we say the term implementation strategies. And the field was grappling with how to de-jargonize that for initial 5 years. Well, conceptually, the people who designed these terms were obviously very clear of how different they are. So implementation context, again, sort of the outer context of policy, plans, legislation, inner context of the hospital, how that affects implementation and implementation outcomes. Implementation theories and frameworks, they essentially provide us and guide us with sort of a structure to enable and understand implementation. Implementation outcomes are sort of some of the discrete outcomes we've talked about already, things like adoption, fidelity, feasibility, scale up, sustainment, implementation cost. So tomorrow we'll go through the definitions of all these terms and how you sort of measure them. So I want you to sort of briefly go through these terms again, and hopefully by the end of this week we will have a better idea and definitions of these terms. Okay. As I said, the field was grappling with these jargons. We found out this is the most interdisciplinary field that I've ever worked in, and it is so difficult to communicate these words and principles with stakeholders, so much so you lose them every time. Hence, and we were having this discussion with Jeff Curran at the masterclass he does with us. I think he's from University of Washington, but somewhere in the US. And he comes down to the UK, and when we do our masterclass, which is an annual course we do in summers, should you like to come to the UK and do that, we were discussing on, actually, over the break, I said, well, I mean, I really lose people when I talk about implementation science if they don't work in the field. What should I do? What should we do? And then he introduced the slide, and I think that was a eureka moment. So much so we encouraged him to publish the slide. So it's the first time in Implementation Science Communications Journal this sort of slide deck was published. It didn't have the figures. I took it from one of our colleagues who work in implementation science, but it definitely had the definition. So he says there's a very non-scientific way of defining implementation science terms. For example, he calls intervention, practice, or innovation a thing. Now, can you give me an example of a thing? I think we also mentioned it, the thing, or this, when we were talking about it an hour ago. Can you give me an example of intervention? Any intervention, any health domain? Come on. Who's going first? Everybody's going to go, so no pressure. Intervention, examples. Yeah, you were saying something. Yeah. And yes. A policy. A policy includes various intervention. But what's specifically within the policy? So policy includes evidence of an intervention. So what would that intervention be? Maybe think you're a patient and you're accessing services for diabetes. What would be an intervention? What are you given? What is the management of diabetes, for example? Therapy, okay, yeah. Therapy. So therapy is an intervention, yeah. Any therapy for any condition is an intervention. That's absolutely right. Any other example of intervention? Cognitive behavior therapy given in secondary care is an intervention. It has been clinically tested. It's a clinically effective intervention and an evidence. Any other example of intervention? Yes? Absolutely. HIV testing, diagnostic intervention for HIV. Any other intervention? And this has been clinically effective and proven. It's a thing. I want you to, if any one thing I want you to take from today's session, it would be this slide. Any other thing? I feel like cameraman definitely has a thing. Yeah? You were saying something? No. I thought you said. Okay. Sorry? Blood glucose testing. Yes, we were talking about it. That's a thing. Tested, clinically effective thing. All right. So we can think of things in any cardiovascular sort of ECG is a thing. It's a monitoring thing. Yeah, it's an intervention. So any diagnostic management sort of intervention would be a thing. So if you look at a patient side, any services you get is a thing. Yeah.
Does it have to be a thing that has been clinically tested? For example, in the field of positive psychology, if I were to talk of mindfulness or So the question, so I'm asking, in the field of positive psychology, for instance, if I refer to mindfulness or keeping a gratitude journal, does it have to have been through clinical trials to be a thing?
So to answer to that question, a thing cannot be clinically effective also, but it's still a thing. It's in the process of getting clinically effective. Mindfulness, however, has clinical effective evidence depending on the condition, for example, dementia and so on and so forth. So because they mention innovation, innovation is sometime a new test to sort of lateral flow test when it first came without evidence would be an innovation. So that's also a thing. Yeah. Okay, we kind of know what the thing is. Now the thing, as I said, it could be clinically effective, or you may be interested in finding out if it's clinically effective. So effectiveness research looks at whether the thing works. Blood glucose monitoring, does it actually work in an uncontrolled environment? That would be clinical effectiveness research. And other example, we had an example of HIV testing. Is it actually, do you actually get a lot of false positives? Then it's not maybe that clinically effective. Yeah, so clinical effectiveness research looks at whether the thing works. Are we clear with these two terms? Any sort of confusions? Anyone online? Any reflections or clarifications required? Yeah, clear with the thing, and effectiveness research is testing the thing. You'd be surprised how many researchers working in public health wouldn't get this. This is very complex and very simple, I feel. Okay, implementation research looks at how best to help people, places do the thing. Now, if I want to deliver therapy via school counselors, how best can I help the school counselor deliver CBT? How can I help a school counselor give therapy to students? How can I help? What do you think they would need? So setting is a school. Sorry, somebody said something. No? Okay. So I'm in a school. There's a counselor. Counselor knows that therapy works. Counselor knows what the therapy entails. 5 sessions. And now this therapist, counselor is giving therapy to someone with sort of anxiety problems. How can I help? What sort of help would this person need to do the thing, to deliver the therapy? And you do that all the time in interventions. Yep.
Maybe skills, capacitation.
Absolutely. Training. So training. This counselor would need training. They might sort of have had the manual, but they might need more training, facilitation support, active, passive facilitation, and support in terms of sort of resources. What else would they need?
And sometimes even after the training, there are things that we call the algorithms, those steps that can guide you to do certain thing without the trainer or the teacher being there. So you'll be looking at those steps, how to assist you. So we call them the algorithm. In case in the HIV we have that it will be plugged on the wall. So whoever is doing the test will be looking at it if they feel like they are in doubt of doing the.
Absolutely. So there can be awareness material, but there can also be, we call it an implementation blueprint, how to do this, guidance, as you said. Yeah, absolutely. What else would this person need? So implementation research, coming back, is trying to help this person whichever way possible. And one thing that is of profound importance in the field of implementation science is these strategies. And I think you talked about some of these: implementation blueprint, training, and resources. So these are all the implementation strategies that are the stuff we do to try help people and places do the thing. So implementation science is overall sort of trying to understand implementation. But the support strategies that you mentioned are the implementation strategies: training, resources, and you will see there are 73 of these strategies in literature that have been compiled, and we'll discuss them. Main implementation outcomes are how much and how well they do the thing. I think to understand this, you need to know what patient outcomes are and what service outcomes are. Only then we will understand clinical outcomes. Okay, I was thinking what was coming next. Okay. So the social worker, Enola Proctor, she said we need a really sort of clear, common understanding of implementation outcomes. How do you differentiate what you are measuring? Is measuring implementation, or is it measuring the thing, which is intervention? So she said she sort of divided these measurement outcomes into 3 domains: patient outcomes, service outcomes, and implementation outcomes. Patient outcomes are something which we are very, very familiar with. Anything that you're doing would have a sort of a direct effect on patient outcomes. Can you give me an example of patient outcomes? Here it talks about functioning, symptomatology, and satisfaction. In your field, give me an example of patient outcome. I mean, the answer is there. You just need to correlate it with your...
Patient outcome would be maybe pain relief for a patient that came with backache, and functional ability. Maybe if they came with reduced function, and then the outcome would be improved or full functionality.
Yeah. So in this example, great example she gave, reduction in pain is one of the primary outcomes. Secondary outcome she mentioned was improving functioning. And there are different scales to measure this, and we use that in clinical practice all the time. Okay, what about the service outcomes? Service outcomes are more interested in improving services and ensuring they're delivered in a sort of a safe, effective manner. Give me an example of service outcome. Here we have detailed some of them. Safety, timeliness, effectiveness, efficiency, equity, patient-centered. These are the categories of service outcomes. But one of the most commonly used service outcome when you do research is, I'm sure it's the same here as well, length of stay. Yeah, we are really interested in ensuring patient gets a comprehensive service, but then is also discharged from the hospital in time, which is good for avoiding, for example, hospital-acquired infections, and it's good for the hospital in terms of sort of managing the costs. Yeah, so length of stay and quality of service would be sort of key service outcome. And the implementation outcomes, I was talking about these 8 distinct, conceptually distinct, but related implementation outcomes, which are feasibility, acceptability, appropriateness, adoption, fidelity, penetration, sustainability, and costs. And here we're trying to measure how do we know if the thing is, so it's very difficult when I talk about these terms, again, people really get confused what do they mean. So again, in our group, we try to sort of oversimplify them. So something which is feasible may not be acceptable, you know. A drug which is feasible to implement might not be acceptable, like a vaccine might not be acceptable for patient groups. So feasibility is anything which is easy to do. Acceptability is it preferable by different stakeholder groups? appropriateness means if it's actually worth doing. Is it appropriate for this setting? Does it chime with the needs of the population on the ground? Adoption would be if it's actually done. I think I kind of disagree with this. Adoption is more once you're introducing an intervention into a hospital. Were they able to sort of adopt it? They might not have fully done it, but there's sort of some level of actually doing it. So partially doing it could also be sort of adoption. Fidelity. What is fidelity? I bet quite a few have better grasp on the language than I have, but what is fidelity, you think? Fidelity is if an intervention is intended, if the intervention is delivered as it was intended. Which means, well, I need to now give therapy. This counselor is giving therapy in the school to this child with anxiety problems. It includes 5 sessions, and 5 sessions have to be delivered, and there are different components in 5 sections, so you can't just do half section of one and half section of the other. So is the counselor delivering therapy as it was intended would be fidelity. And there are a multitude of frameworks to understand all of these terms. So if it is done well, so essentially you are assessing the quality of delivering therapy. Penetration would be, has this sort of penetrated to all the wards? For example, if it's an infection prevention control intervention, hand hygiene, for example, has this been penetrated to all the wards? Is it sustainable in the sense once the research funding or the program ends? Are there sort of enough exit strategies to make the intervention sustainable? Is it a habitual practice within a system? I mean, at least in my career, I've seen so many interventions. They're all piggybacked on nurse's shoulder. And only recently I saw somebody posting on LinkedIn. They're trying to see how they can help community health workforce be sort of well. So essentially well-being of community health workers because of the burden they have. I think last 15 years, we've been giving community workers and nurses more work. And now we're trying to understand, hey, how do we improve workplace well-being, for these sort of cadre of workforce? And a new field is emerging, which is called de-implementation. You don't need to be doing things to improve things. You sometimes need a macroscopic health systems approach and do less but better. So we are coming up with de-implementation frameworks and constructs for measurement. So yeah, sustainability is a tricky one in that sense. Costs. Sorry, got a question.
Yes, I have a question. I want to understand fidelity in for example, in nursing profession. Does fidelity also talks to the issues of, harm done to this person? For example, the example that you gave of counseling a client and doing everything that's expected. And now I'm counseling the client, but I'm bringing my own things that are not part of this guideline or the policy. Is it part of fidelity? Because I want to understand it clearly so that when I apply it, I know.
Very good question, actually. I think that boils down to what you consider evidence. Evidence, there's always there's a debate going on at the moment. Would AI be able to detect ADHD, for example? In the UK, the waiting time to detect ADHD is 3 years. Some of our sort of technologically savvy colleagues who are AI experts, they came into the room and they said, well, you're anyways taking 3 years. There might be some false positive, but we'll be able to detect it sooner and you'll be able to manage it sooner. I'm sort of bringing this point of view to make you understand how evidence is not a fact, and it's generally a gray area. In healthcare, evidence comes from clinical trials, but it's also, there's a component of clinicians' judgment. So if you can explain that extra intervention added due to the experience of that clinician, which generally should be included in the national guidelines as well, because they would have a sort of expert consensus survey with the clinicians as well. So that aspect of intervention should be included in the beginning. However, sort of you can challenge it and include sort of localized, contextualized, bespoke sort of delivery. So what I'm trying to say is, ethically, you should use what the guideline says. But for all the assessments in medical field, we would rely on guidelines plus the clinical judgment, because they understand the importance of that, what do you call it, tacit knowledge. So that tacit knowledge is really important. But what you're saying might not be just the tacit knowledge, it might be knowledge of working in the context. For example, this is very far, for example, I think I was at the top of Naval Hill yesterday and was trying to understand where the townships are and how, even though there's evidence to give some services in the sort of a national hospital, but it's very far for them to reach here. So obviously it's sort of the transportation issues. So you might be able to give suboptimal care and go close to the community. So that might not be in the guidance, but that's a contextual knowledge that might help, if that makes sense. Does it? Yeah, okay. Sorry, I go into too many examples and I realize I have a lot to cover. So yeah, these are 8 conceptually distinct and related implementation outcomes. There are different frameworks, qualitative, quantitative measures to assess these. And if you are designing a research study, I would highly sort of recommend you use implementation outcomes framework and use some of these outcome measures as well, along with your patient and service level outcomes. I'm not going to go into cost effectiveness today, it's in the other session. But again, coming to the field of implementation science, minding the gap, we are trying to address 2 main issues. We're trying to address individual level factors, behavior, that might lead to change in practice. And then we're trying to address issues within the context, trying to understand that, not necessarily change everything. And how that has an effect on these implementation outcomes that I mentioned. So that's where the focus of the field has been. Okay. I think we will move to the next slide deck now, which is on theories and frameworks. So the second slide in the email, thank you. Any questions for this first session? I divided the session into the introduction for implementation science, so that was your recap. The next session now would be for 45 minutes around theories, frameworks, and approaches. I thought it was very important to place the field first before going into the theoretical understanding. We have a question here.
Yes. Thank you so much for this interesting presentation. Implementation is indeed a challenge in developing countries. But then I've got general questions. So since I'm still new in this space of implementation science, I think you'll help me to fit my questions in within the context. So I think the main challenge that we have, especially in epidemiology, is that whatever findings we may come up with, the success of the implementation, the powers are centralized with the policymakers. And then we've got challenges of corruption. Let me just give you an example. Currently we are having an outbreak of food poisoning to
2 kids, right? So the Department of Health will send EHPs to do the investigations and so on. But now the EHPs from the Department of Health should submit their reports to the municipality where the politicians are. So whatever findings at the end of the day, the outcomes will be determined by the municipality, officials and so on. That's one example. And then the other challenge is the issue of business and job opportunities. We know, for instance, let me give an example with regards to the link between obesity, maybe smoking and lung cancer, for instance. So we are talking about business, we are talking about jobs. So as much as the findings may indicate that high consumption of sugar, leads to obesity and so on, as well as smoking and alcoholism and so on. But at the end of the day, these are jobs. It's not going to be easy to implement that. And lastly, it's on sustainability. We once had a high incidence of SAM in Mpumalanga province. There was a good collaboration between the Department of Social Services, where the mothers of the malnourished children would get vouchers. So it went well it went very well until the politicians intervened, because now they wanted to be the ones who are supplying the mothers with the whatever food products and so on. So there was a lot of fighting then, and then the program was not sustainable in that way. Yeah, so that is all. Thank you.
Oh, thank you for all those sort of questions and reflections. I think, well, epidemiology is trying its best to come up with clinical effectiveness evidence, but you're saying obviously it's at the coal face how we're seeing with other examples things fail and the issues are multitude. What we are trying to do here is just provide you, I can't tell you how to solve corruption, governance issues within a system. There have been sort of some tested strategies of accountability and transparency, but you can't sort of solve these problems. What we could do is have a holistic view of thinking through some of these issues and making sure we are not sort of dropping one element from that holistic view. For example, you talked about sort of sustainment in SAM, severely sort of acute malnutrition, and you talked about the outer context and issues with the outer context. What we will do is very systematically say, well, look, in severe acute malnutrition, these are the issues at a community level, at a primary, secondary level. And then we will try and come up with the best strategy to tackle them. The strategy comes from evidence. The strategy comes from sort of stakeholder input. It comes from patients. And then you test if it works. So we are, again, scientifically trying to study all these problems. I have an example where we were trying to implement Friendship Bench in South Asian women in South London. The Friendship Bench intervention I mentioned. And we identified one of the facilitators was other South Asian women were really happy for free as volunteers to talk to the other women in primary care. So the barrier is we don't have workforce. Even though it's a high-income country, I doubt now, but we still have workforce issues at primary care level to sort of deliver low-cost intensity interventions for depression, for example, for this population, especially for a minoritized population in South London. So this is a barrier. We can't have more cadre of workforce, or we can't have a culturally appropriate counselor at a primary care. That's not possible. Private healthcare is too expensive. So how do you manage that? This is an issue. Well, this is a barrier within an inner context, and I identified sort of a solution, which was our team identified a solution, which was essentially involving peer support workers or sort of other South Asian women who are ready to help. So we try to sort of distill and disentangle each barrier and, manage it with each strategy, and then try to sort of roll it out and see if that's effective. So in the project that you mentioned, we could sort of use a similar approach. It is very messy, and as I said, it's like raising a child. It's complex, and you will have surprises, but we'll try and see if a scientific way might help it a little more than usual. And I think that's what the field is trying to do. So can't give you sort of answers to those really difficult questions, and just that sort of augments the facts that we're working in sort of a complex system. Yes.
All right, thank you. You mentioned this in passing, the de-implementation framework. And now that we are tapping into the theoretical part of it, I'm just wondering if you're going to touch on it. But if not, can it also find expression in the next session, please? Thank you.
I think, yeah, really, that's such a good comment. If you think there are areas of work that you want to learn more, because we would generally spend one full day, 9 to 5, discussing, making a case for implementation science, and one full day for theories, one full day for frameworks there. So I would be sort of briefly touching some frameworks and not going into detail. And we are not covering the implementation next 45 minutes, unfortunately. But either I can definitely sort of circulate that, but I can also touch base on some of those frameworks. And it's such a new field. So, I mean, I also feel I'm not sort of fully equipped to give you a proper framework for the implementation, but I can tell you what others are doing. And as we speak, our team is developing a new de-implementation science framework as well. But that's a very helpful sort of thought. So any particular suggestions you have, please feel free to jump in. Anything online before we move in? Any questions online? No? Okay. All right. Kurt Levin once said there's nothing more practical than a good theory. And I just love this sort of phrase. And there have been multiple studies to sort of test if it's true or false. And we'll try and learn some of this now. So the theories that we are going to learn, they would have engulfed theories from the past. So traditional sort of socio-cognitive sociology or psychology theory, but then there are some specific implementation theories as well. So implementation theories are providing an understanding of different aspects of implementation. They also, and a theory is made up of different free radicals. And a theory is trying to find how and if there's an association between those free radicals. Yeah, it's a very loosely way to put it. We're trying to set up relationships between sort of variables, radicals, and predict, sort of do some prediction modeling. And theories provide an organizing description of a system that accounts for what is known and explains and predicts a phenomena. It really helps us sort of bring in our different thoughts. When I think of an issue, I have 10 explanations for it. And if you bring a theory, you can place these 10 thoughts and make sense of what is happening. And here are some of the sort of uses of theories. I'm going to put them all at once so that, oh, sorry. Okay. It is really helping us summarize what is the current evidence base. And as I said, it really helps us structure thinking. I don't know, some people are very intuitive and they can structure their thinking. The others, sort of personality-wise, they really need a journal to sort of make sense of their thoughts. So theories in that case really help structure thinking and guide research. And within, or I should say outside a theory, is a framework. So within a framework, there's a theory underpinning. So a framework around a theory provides a structure where we can accumulate evidence and communicate this with different research groups. And within implementation science, we are trying to do 3 things. We're trying to understand barriers and facilitators for implementation. And the theories for these are called determinant theories or determinant frameworks. We're trying to understand why an intervention works. So we know an intervention. For example, somebody talked about a diagnostic tool, HIV diagnostic tool. And we see that it helps in detection, but it actually also helps us in creating a rapport with the patient where they find a safe space to open up. So we are thinking of different mechanisms in which different diagnostic interventions or management or delivery interventions or treatment interventions work. So why does a CBT work? So essentially sort of unpacking mechanism of change and trying to modify how it influences patient service and outcome and implementation outcomes. So in a nutshell, barriers would help us understand what needs to change, and mechanism of action would help us understand process and understand process of change. Let's try and... So in epidemiology, we have different ways of understanding how an effect leads to sort of an outcome, yeah? In implementation science, that causal explanation comes from understanding mechanism of action, if that makes sense. So we explicitly conceptualize the causal process by which interventions are expected to have an effect. So I gave an example of diagnostic. For example, we are using an intervention called DETECT to detect diabetes distress. And that DETECT is actually an assessment tool. So apart from telling me the score at the end of the day, it is also helping me sort of understand how that tool might have a sort of impact on the patient. So we've spoken to multiple patients and they said, well, this just sitting with the clinician and talking about this tool sort of had a sense of self-compassion in me. So that self-compassion is a mechanism for action and is a causal process. We are coming up with ways to sort of do that in a clinical trial context as well, using hybrid designs, which we will discuss soon. Not soon, on I think day after tomorrow. Okay. So what is a good theory? Good theory would mean that there are different free radicals, variables, or constructs, whichever you want to call it, and that there is clarity on how they are distinct from each other. There is clarity of how one construct relates to the other. And this is very difficult to explain without sort of getting into a specific sort of examples. So we'll try and do that in the next slide. Theory should also have elements of testability, measurability, and it is able to explain a concept in a sort of a simplistic way, in a parsimony. So parsimony is if you have 10 explanations of a concept, you would choose the simplest theory. So that's one of the sort of criteria for having a good theory. Good theory is also that it's applicable everywhere. Have you heard of the innovation diffusion theory? Okay, I think we'll discuss that. A good theory also has an evidence base. Yeah. And there are these two papers on Susan Mickey, she's at University College London, one of our colleagues. She psychologist by background, but does a lot of work on sort of global health. And she was trying to argue a case how these theories are useful for implementing. So I think that it took really long time for us to sort of involve different theories in implementation. It didn't start like that. And then there's work of sort of Susan Mickey and Carl May, where they're trying to validate the theoretical domains framework. Sorry, not Carl May. Carl May is another that's NPT. Sorry, theoretical domains framework again by Susan Mickey. So first she made the case, and then she's trying to sort of validate the case for the theory. Again, I think we briefly touched on this, how theory is at the heart of a framework. Framework might give you different components, and you might sort of tick boxes, oh, my intervention ticks this box of a component, but beneath it would be one or multiple sort of theories. We'll come to more examples. Per Nielsen, he is a sort of a Dutch guy, so works in Netherlands. He was bogged down by the number of theories that there in implementation science, and he tried to sort of, in 2015, tried to conceptualize or compartmentalize is the word, these theories. Well, he said, in implementation science, you have process models. And to be honest, some of these models and theories, they were there before the term implementation science was coined. So you might come across people working in knowledge dissemination, qualitative research. They might be using all these things before. This is all trying to bring all of this together so that there's a common language and common understanding. So there are process models that help us describe the process of translating evidence into practice. Then you have determinant frameworks, classic theories, and implementation theories, essentially trying to understand and explain what influences implementation outcomes. So we talked about process model. A lot of randomized controlled trials or cluster RCTs would have process evaluation embedded. And those process evaluations were using process models. So everybody knew when there's clinical effectiveness evidence, at the coalface it fails. So they really wanted to understand implementation. But the maximum they could do at the time was look at process models and come up with some sort of conceptualization of describing how the process went. Because in publications, you would never be publishing an implementation blueprint. Like, for example, if a nurse is implementing a new checklist, you would never publish, you'll publish the effectiveness of the research, clinical effectiveness, but you would never publish any data on implementation. It was very difficult to publish implementation data, and mostly you would really get it from the tacit knowledge of program managers. And if you speak to them, you'll get the sort of nuances of why or how the process of translating research to practice works, because there was a lot of funding on implementation, a lot of funding on research, but when you publish it, it was more around clinical effectiveness than implementation nuances. So coming to the third aspect that is included in implementation theories frameworks is evaluate implementation. I think we talked about evaluation frameworks briefly. So we talked about Proctor's implementation outcomes, those 8 distinct implementation outcomes. That's the evaluation framework, an example of it. There are multiple there. So this was really helpful for sort of compartmentalizing which theories we use. The author is also trying to say that we use different frameworks or theories in one. For example, a determinant framework could be used alongside an evaluation framework. So determinant frameworks are where we will go to one determinant framework in detail, where we're trying to understand barriers and facilitators to implementation. Some of the issues that you talked about would be sort of unpacked in determinant frameworks. So an example of using 2 implementation science theories, frameworks, and approaches would be a determinant framework and an evaluation framework. I think it'll become more clearer when we go to the... Oh yeah, next slide. Okay. All right. So these are the 3 theoretical approaches that Peter Nielsen says we use in implementation science. First is describing and guiding the process model. The second is understanding and explaining what influences implementation outcomes. So here you have determinant frameworks, classic theories, and implementations theories. We will spend a lot of time understanding one determinant frameworks, which is the most commonly used, which is called Consolidated Framework for Implementation Research. Has anyone heard of it before? No? Okay. Classic theories are classic psychology and sociology theories. So one example of classic theory is Rogers' theory, I think in 1962 or something, innovation diffusion theory. So what Rogers said was, if you're introducing anything into a system, there would be some people who are sort of easy uptakers. So they'll uptake the intervention very quickly. For example, if you introduce a digital intervention, and some people would be like, oh yes, you know, really excited. I think this is 35% of them. They'd be super excited. And then you have in the middle who are slow adopters. And towards the end, you have, he called them loggers. So I think 15 to 20% of the people would be really resistant. So that's an example of a classic theory, principle of sort of innovation of diffusion. And this diffusion theory is applicable everywhere. It's even applicable in sort of social context where, for example, internet or mobile was introduced. Some people were sort of really quick in uptaking, the others were relatively slow. And then there's a middle group. So that's the theory that you can apply across discipline. That's an example of classic theory. Other psychology theories, psychologists in the room would know are also under this domain. And then there are sort of implementation theories like NPT, normalization process theory, which essentially says how do you make an intervention a normal, habitual part of working in a practice. And then there are different constructs. And that was developed by Carl May and colleagues, I think at the time. He was in up north in England, but now he's in London School of Hygiene and Tropical Medicine, you might have heard of. Okay. And then we have theories which are looking into evaluating implementation. These are implementation outcomes framework, Proctor's framework we discussed, and then there are other frameworks like REAIM, developed by some of the colleagues we work with. So yeah, we will try and see. Look, it's very difficult to go through each framework. So implementation theories also has de-implementation framework. And we're sort of learning more about some of these as we go. And I think there are, if I'm not wrong, last I checked, there were 61 of those. So we will try and cover a few today and a few tomorrow, but not necessarily cover those 61. And I think one thing to mention is we were using a framework for sustainability, which is an evaluation framework. It's the NHS sustainability model. And it talks about context, processes, and evidence, and how that influences sustainability of any intervention in the NHS. And I was, just before coming here, we had a workshop with our mental health implementation network. So we have people from across the regions in England, and we were doing a group work, and we tried to roll out, use that model in groups. Out of the 3 projects, two groups were sort of acing it. And there was a way to calculate an average, and weighted average. Some people were sort of, really doing well. There was another group which was implementing intervention for the minoritized population. They literally disregarded the tool. They said, well, look, patients are not at the heart of this tool. In the framework you show, and my postdoc was having a really hard time with the sort of EDI lead from that team and trying to sort of make sense of how to use that framework. So I think what we came up with is we took their sort of comments on board and we tried to include additional factors in our framework. Why I'm narrating this example is these frameworks, you don't have to take them just as is and sort of, go away with them. And also not fight too much over them, because this is a way to springboard discussions. It's not necessarily sort of hard and fast that you have to sort of tick every box. Idly, in an ideal sense, you would tick all the components of a framework, but this would be more to guide your thinking. I think what I've seen goes wrong in using these frameworks is I have a lot of PhD students, they'll try and use this framework. They're like, no, Shalini, but this is not here. I don't think so. This framework is appropriate. I'm going to combine 3. And I think we lose an oversight of why these frameworks exist. They're just existing for us to have a terminology to frame our thoughts in a way that is generalizable. So always sort of remember that's how you would be using some of these frameworks. Unfortunately, you will have to use these frameworks because different funders, and this is almost a mandate, that if you're studying barriers and facilitators to implementation, you will have one framework mentioned from determinant frameworks. If you're studying evaluation, you will mention one of the frameworks because the funders have seen the value and you will have to use them. And you may argue against it, but yeah. So yeah, when I'd done this slide, I think there were almost 60 implementation theories. Last time I checked, there were a few more. So, Sarah Birkin talks about how do you select implementation science theories and frameworks. So we can sort of briefly go into that factors we need to consider while selecting a theory. So essentially, can you justify the main purpose of using that theory? For example, if I'm using Proctor's implementation outcomes framework 18, the eight distinct outcomes, I can say, look, I want to not only understand implementation, I want to assess implementation. That's why I'm using this framework. So I'm able to justify that. Are there enough sort of resources and skills within your team to be able to sort of use these frameworks? So in our funders would sort of request like 5 to 10% FTE, full-time equivalent for an implementation scientist to be on board for efficacy, for effectiveness research. But obviously if it's an implementation specific study, you need more time. You will have sort of junior staff, postdoc researchers, but you will definitely have to budget for somebody who not only understands the context, but also understands this framework. What I've seen is, for me, when I work in rehab and mental health, because I conceptually also know the concepts, it is so much easier to apply these frameworks vis-a-vis when I work in sort of surgical site infection, which I'm not an expert in. I've worked in the project. So again, sort of really important to know the context and then use implementation science. So what I see now coming up is you will have group of people working in diabetes and then diabetes and implementation science. So there's a super specialization coming up in the field, which can be detrimental at times. How will you sort of operationalize that framework? How would you sort of use that framework to have you worked in qualitative research? For example, you develop interview guide. So how would you use that framework to develop an interview guide and then take it out, collect data, and then how would you use the same framework to then analyze your data? So it's very important to sort of operationalize. And why are you, one of the common things reviewers often ask us, why are you using this framework over the other? And then, so yeah, I need to sort of conceptually understand them a bit, but as long as you can rationalize the use. Okay. I'm still not perfecting this. Am I going? Yeah. There are different phases of implementation. One says you want to start implementation, but you want to think if I can actually implement this innovation or even policy. So you will do some pre-implementation work. and use process model. Then you are rolling out an intervention, and you can sort of use evaluative framework at pre and post implementation. Essentially, you establish a baseline of indicators, and then you compare it with an end line. So you could sort of look at pre-implementation, post-implementation. Determinant frameworks mostly are used during implementation, where you're trying to... Determinant is, what is a determinant for implementation? What is the barrier and facilitator? So you can use them at pre, during, or post, but mostly it's ongoing assessment and adjustments. And implementation theories would embed all the frameworks at all the stages, essentially trying to underpin how these frameworks work and what are the mechanisms of action or sort of mediators. Okay. Now we will go into one framework in detail, and I'm hoping to do a group work exercise where you would be using this framework. So that would be at, okay, I think we're running behind a bit, but when's the lunch? No. Okay, so I want to spend 15-20 minutes on one framework and then give you sort of group exercise. It would be nice if 6 of you ideally could sit in one group. I don't know if we can sort of move tables around, but maybe there could be one group here, second, 3 and 4. So we have 4 groups, and I'll give you exercise, and you will use that exercise to come up with sort of determinants of implementation. So we'll first go through the framework, and then we'll do some group work, and I'm sure you'll learn from each other as well. Okay, we'll now pause for lunch because we should. 12:15. Ah, see, heaven is on my side today. I will then go through the framework now, so that by the time you could revise this while you're having your sandwiches. Okay. So we understand the difference between determinant frameworks, implementation theories, and evaluation frameworks a bit. Okay. We will now focus at the most commonly used determinant framework. When I was doing my PhD, I think I didn't realize I was using this framework, and I retrospectively used it to analyze the data. So it was so helpful to see, oh, I was missing these domains than others. So Consolidated Framework for Implementation Research, it was developed by Laura Dromshore in 2015, around that time. And it's a meta-theoretical framework, and it contains 5 domains. So whenever you're trying to implement an intervention, you look at the intervention characteristics, you look at the inner setting, the outer setting, who are the key players involved, and what is the process of implementation. So some of you are working on your projects already. If you are during implementation phase, or you're trying to design a study, always think about these 5 core domains, because all of them would have an effect on sort of implementation. And within these 5 domains are 37 constructs that affect implementation process. So the first is intervention characteristics. This one has got 8 constructs. Here we're really trying to see, is there enough evidence to support this intervention? We talked about the HIV diagnostic tool. Is there enough evidence that that can be clinically rolled out? Yeah? So we're really interested in the evidence strength, but also what the stakeholders feel about it. Sometimes what happens is when you take an intervention, for example, we were doing some work on that surgical site infection project, and there was something about when should you start administering the antibiotic prophylaxis. And there's a WHO guidance, and then countries have their local guidance. And there was a real fight in between the anesthetists on what should be the time of administration. So we were doing an implementation project and we did a theory of change workshop with them. Most of the time, there was debate on the evidence strength. So we realized that's not one of the, so we were selecting which interventions to implement. So we thought, well, looks like for this intervention, we need to go back and do a bit more work on contextualizing antibiotic prophylaxis for that population. Because I think there was something around anaerobic and aerobic bacteria, where when WHO did the research, they focused more on one over the other. And in this context, they said it doesn't work. So I'm just giving you that example there. When you are rolling out, again, look at the evidence. Again, look at what stakeholders feel. There has to be some degree to which this intervention meets the local needs. Yeah. So that has to be a priority within the hospital. So there has to be some element of adaptability. And what is the complexity around that intervention? So when people have designed a clinical effectiveness intervention, they generally would sort of unpack quality, packaging, and complexity issues. We would also look at the cost of intervention. Can that be actually rolled out in a hospital? That's very different in the sense it's not looking at cost effectiveness of the intervention, it is looking at cost of implementation. Slightly different things. For example, if I am taking that therapy to the counselor and they'd be delivering it, so you would need additional training, you would need facilitation, you would need IT, and all that costs money. So what is the implementation cost of that intervention? So when you're looking at an intervention, you try and see all these sort of aspects of intervention source. Intervention source is so critical. So much so that it has a direct influence on implementability. So we are working in a project where we're trying to integrate addiction and mental health services provided by 2 different departments in the UK. So in one project, we didn't have the innovators who developed the intervention on board. On the other project, we had the professor who was involved in clinical effectiveness of the intervention. And what we found was having that innovator or intervention source on board had a massive impact on stakeholder relationships. Where the innovators were not on board, we were never able to clarify the rationale for intervention and not get buy-in. So those sort of aspects also really play a part. So yeah, intervention source is also very important. You need to sort of clearly know who developed this, and if you can get those people, we call them innovators or intervention source people on board, I think that has an effect. So that's intervention characteristics. That's one of the component of health systems. What's the time? Okay, we'll recover a few of them. And then is the inner setting. Inner setting really depends on what the intervention is. In a very sort of non-jargonized way, I would think of inner setting as a hospital. So what are the sort of characteristics within a hospital that might affect implementation? Depending on the intervention, it could be just a ward. And I think it would be a bit clearer when we come to the outer context as well. So 12 constructs in this one. One is networks and communication. Within the hospital, if you're trying to integrate a service between 2 wards, what is the sort of communication between that wards? Do you know the sort of maturity of that hospital or organization? What is the cultural context within that hospital? Is it sort of professional hierarchies are more pronounced than usual? Every organization has a culture, and you assimilate in that culture without knowing you are assimilating. So really sort of important to understand that culture. And then what sort of an implementation climate there is. Is there a general receptivity in introducing new intervention? And it really depends on the sort of key stakeholders that you're involving. Or there is resistance. If a ward is sort of overburdened, and there are individual factors that you're excited about a new thing, and you believe in that concept and you want to roll it out. But there might be still tension for change. Again, innovation of diffusion theory comes in. Some of the organizations or hospitals would provide incentives for doing an additional test, for example. That's rare because most of the health workforce would be on sort of a full-time income. And then it would be really difficult. Then it's sometimes difficult to incentivize. But if you look at community health workers, in various countries, you would incentivize them to do more tests or more sort of awareness generation work. I mean, I can't emphasize the role of goals and feedback enough. So we did this study on surgical site infections, the infection rate. The data was collected by data managers. Infection rates would be assimilated, and then we will discuss that in a meeting. In that meeting, there would be just surgeons, not even anesthetists, nurses, people who are involved in surgical site infection interventions, for example, hand washing. What we did was we included a very simple intervention. We made sure in these meetings, a nurse in charge, a pharmacist, there was no pharmacist, a lot of it was about antibiotics, there was no pharmacist in that meeting when they were discussing infection rates. So we made sure that sort of interprofessional care is delivered in a way that we involved them in the meeting. It was a 9 a.m. stand-up that they do in the ward. And we just ensured everyone was coming. And I think this is as basic as it gets. And after 2.5 years, we saw like 10 to 15% reduction in surgical infection rates without intervening at all. We just made sure the nurses knew why they were collecting this data. So sort of trickling down that sort of feedback to people who are actually involved. And you might think these are very soft things, but they really do have an impact when you sort of test them. So essentially trying to understand your inner setting. The outer setting is sort of more broad, again, depends on the intervention. It could be things like if there's a sort of a mandate from the government to, for example, in the UK, children and young people's mental health is quite topical. During the pandemic, we could see how the sort of rising rates of anxiety and depression in children. So there's a push from the government. So is there a push for managing addiction services? So you really see sort of the external policy and incentives involved in delivering that intervention. And the cosmopolitanism, the degree to which an organization is networked with other organizations. So when we were working across regions in England, the most effective practice we found was communities of practice, where in a non-hierarchical way, we'll bring all the implementers from different regions and they will share knowledge. There's no chair, there's no boss in that meeting, and they will just sort of share they would share best implementation practices. So sort of enabling that network also has an impact on sort of implementation. Peer pressure. Well, if an intervention is delivered in Oxford, then it's delivered in Cambridge. So it's something sort of a peer pressure now, and how patient advocacy groups are sort of mandating for it. For example, in our project, we had to include interventions that target minoritized group because there's a mounting sort of pressure from patients, from community organizations to make sure that sort of minoritized populations' mental health is covered. And then I think nothing is, you can look at the outer context, you can look at the inner context. Nothing changes if you change behavior at an individual level. How many of you have tried to change your behavior on day one of the new year? Like, okay. Gonna go to the gym, gonna leave caffeine. and it's really sort of complex. There was a diabetes project that I was very briefly involved in, but I had such a profound impact. Patients were doing too much to manage their obesity. So they were obese patient going to the gym. And we were like, at the time I was extremely fit, so I used to look down upon on people who couldn't manage their sort of health, you know. I had something called as obesity stigma. I don't have anymore for several reasons, some you can sort of identify. So essentially, we went and interviewed all these obese people who were coming out of the gym, and we interviewed them, and I was like, why don't you sort of involve in healthy lifestyle and do lifestyle changes? They said they want to change. They know it's important, but the amount of stigma that is associated with it is enormous, in the sense, they said, you are interviewing us outside a gym. There's somebody who's very close to me just said, oh man, you've gained a few pounds. Why don't you just go to the gym and sort of shake that a bit? And that lady said, this is so traumatizing for me. I have spent an hour in the gym, and somebody who's very close to me is asking, why don't you do something about it? And she said, I'm going to go home and have that bar of chocolate because this has sort of stressed me this much. So I don't know. So what we did is we used narratives of these people, and we did a sort of an art exhibition. And we wanted people to go around and read what these sort of patients and service users said, and how for them it is difficult to change behavior. Yeah. So again, sort of characteristics of the individual is instrumental in sort of practice change. And you could be motivated by your sort of, you might have inner motivation, or the context might motivate you, or demotivate you, actually. So some people ask me why I work in mental health. I was a trained physiotherapist. I could do just public health research, but then I had a family member who was impacted by mental health, and I was telling them, why cannot you lose weight? And as a physiotherapist, I couldn't help my family member lose weight who had mental health problems. And I was like, why? Initially I was like, of course, I mean, I know everything about evidence. I know how things work. I know research. Obviously I can manage. But then you need to really sort of see the characteristic of an individual to make a change. Some of it is intrinsic, and some of these, as I said, some of these are personal traits. Some of it is dependent on the medication as well. So some medications, like antipsychotics, would make you gain weight, and it's very difficult to sort of then manage it. And what is your individual stage of change? Are you in those people who are easy adopters, or are you the laggers? Yeah. And what is your individual belief in your own sort of capabilities to exclude the courses of action to achieve implementation? What is your individual level of capability? And then I think it's a sort of a broader construct. How are you valued in your organization? For example, if I'm introducing a sort of a HIV detection tool at a primary care setting or HIV clinic, has that nurse who's going to introduce that tool is sort of valued in that organization enough to make that change? And what is the sort of their relationship with the boss? What is the degree of commitment? And these attributes may affect the willingness of staff to fully engage. The relationship I have with my sort of line manager in a sort of HIV clinic may actually impact if I would use that tool or not. Yeah. So now, can you imagine the breadth of reasons why an intervention fails? And every project that now we work in, we try and look at each of these components. Yeah. Sorry. think we will stop here after this question. A, I need food. And B, I'm sure you sort of
I think
also needing one. Yeah, sorry.
Yes, I think you sort of hit the nail. What's the English saying? My English is Bantu one, don't worry. But I wanted to say, with us, the implementation program or process sometimes is being impeded or blocked by so many individual feelings of, for example, the HIV prevention is the first program introduction to the overall HIV management. So because of managers not really taking this program seriously so sometimes when you try to implement some project, because there's no support from the managers, they are only going to intervene or come to the rescue where there are problems. In the initial phase of the implementation, they are quiet, they are mum about it. You will be writing emails saying, maybe I'm going to do this. They will be ignoring your email. And sometimes for us to win is when we start a program, then everybody's on board. So when they only come when things are not happening or are going wrong, sometimes for me it's really a problem for us to implement, because for the virtue of testing, using condoms, those type of things, people don't take it seriously. But those things, they are going to affect the overall program, where now people are testing HIV positive, people are now taking treatment. Now the seriousness of the support will be now when people are taking treatment, which for me is late. We want to get support where we don't want to find our people having that type of a disease in the initial phase, not focusing now on the treatment, the viral load. We want to see our managers talking about this condom, talking about this PrEP, talking about testing, talking about everything, not only come when things are not doing well, which is now the repercussions of us not preventing in the first space.
What an excellent example of co-producing sort of prevention intervention with service managers and implementers. So much so, it's a very good example. In the US, there's a special cadre of workforce called implementation support practitioners. People like all of us who've worked in projects like yourself, who have a real good understanding of why things fail. For example, you said co-production with service managers was sort of critical in this case. And yeah, there's a special workforce that's helping span boundaries from academia to implementation, and they're called boundary spanners or implementation support practitioners. So some of this knowledge you generally don't get in publications or case studies, for example. But thanks for sharing, appreciate it. Okie doke. If there are further questions, you can find me during the break, and we will have group work, and we'll try and sit in groups when we come back. Over to you.
Actually, I'm just announcing that we shall be going to lunch in a minute, and you will follow myself and Mr. Zulu over there. We just go to the foyer. It's just across the road here. That's where we shall be having lunch. We also have restrooms in there, so don't worry. So we shall have lunch until 1 p.m. and we'll be back here. Oh, good question. Sorry. You can leave your stuff. I have requested that they lock up once we are all gone, so it will be safe. Thank you.
Thank you. And when do we reconvene? Is it 1 hour? 30 minutes. Okay. Yeah. I need food.